Namaste Vidya. Namaskar Krishna. A very good morning to you all. Myself, JV'n Dr. Ravi Jain, Assistant Professor, Department of Practice of Medicine at Faculty of Medical Science, JAYOTI VIDYAPEETH University. Today we are going to continue with our previous lecture on Inflammatory Bowel disease. In the previous lecture we have studied about ulcerative colitis. In today's lecture we are going to study about Crohn's disease. So this picture is the repetition of the previous one, in which we have seen the skip lesions that are present in the Crohn's disease, where in the ulcerative colitis there is continuous lesions. There was backwash uveitis, and the lesions were spreading in the reverse direction. So now we come to the macroscopic appearance of the Crohn's disease. It can affect any part of the gastrointestinal tract, from mouth to anus. So any part of the GI tract can be affected from mouth to anus. It occurs in 30 to 40% of the patients which are having small bowel alone. 40 to 55% have the disease involving both small and large intestine, and 15 to 25% have colitis alone. The terminal ileum is involved in 90% of the cases, and rectum is often spared. Whereas in ulcerative colitis, it was starting from the rectum. In Crohn's disease, the rectum is usually spared. It is segmented with skip lesions or skip areas in the midst of the disease intestine. So, skip lesions are the typical features of Crohn's disease. Perirectal fistula, fissures, abscesses, and anal stenosis are present in 1/3 of the patient. So, in 1/3 of the patient, we have perirectal fistula. So, fistulas are there, fissures are there, abscesses are there, and anal stenosis are present in 1/3 of the patient. It is a transmural process. In case of mild disease, there is aphthous or small superficial ulcerations that are present. More active disease, that is systemic ulcerations, fuse longitudinal and transverse. There is cobblestone appearance that is characteristic. There is active stage. In the active stage, it is characterized by focal inflammation and formation of fistula tract. So there is focal inflammation and formation of fistula tract, which resolves by fibrosis and stricturing of the bowel. So the fistula tract resolved by fibrosis and stricturing of the bowel. The bowel wall thickens and becomes narrow. So the bowel wall becomes thick and narrow and fibrotic, leading to the chronic recurrent bowel obstructions. There is cirrhosis and mesenteric inflammations, which promotes adhesion and fistula formation. So fistula formation is also present in case of Crohn's disease. So this is the cobblestone appearance that we have just seen, or we will see in the next slide. So this is a cobblestone appearance. Aphthoid ulcerations and focal tract abscess with loose aggregation of macrophages, which form the non-caseating granuloma. So there is granuloma formation. There are aphthoid ulcerations and focal tract abscess with loose aggregations of the macrophages, which form non-caseating granulomas. Granulomas are the pathognomic feature of Crohn's disease. So the formation of granuloma is a very important feature of Crohn's disease. These can be seen in the lymph nodes, mesentery, the peritoneum, liver, and pancreas. So granulomas can be seen in the lymph nodes, mesentery, peritoneum, liver, and pancreas. The histological features include submucosal or subserosal lymphoid aggregates away from the areas of ulcerations. There are gross and microscopic skip areas and transmural inflammations. Now, the clinical presentation in case of Crohn's disease. It can be present as acute or chronic bowel inflammation. So there are two kinds of inflammation that can be present. These are acute or chronic. There are two patterns of the diseases that are commonly seen. We have fibrostenotic obstructive or penetrating fistulas. I will again repeat the two patterns: fibrostenotic obstructive. So there is fibrosis, stenosis or narrowing and causing the obstruction. And the second one is penetrating fistulas, means fistula formation. The penetration is there, there will be the formation of fistula. The major symptoms in case of ulcerative colitis, also Crohn's disease, are abdominal pain. In Crohn's disease, we have abdominal pain. diarrhea and weight loss. So there is pain abdomen, painful will have, there is diarrhea and there is weight loss. It causes subacute and even acute intestinal obstruction. So it can lead to subacute or acute intestinal obstruction. The pain is often associated with diarrhea. So there is pain that is associated with diarrhea. The diarrhea is watery and does not contain blood or mucus. So there is no blood or mucus in cases of diarrhea that was present in ulcerative colitis. The patient lose weight because they avoid food since eating provokes pain. So because eating provokes pain in the patient, hence he avoids food, and due to which there is progressive weight loss. The weight loss is also due to malabsorption and presents the features of fat, protein, and vitamin deficiency. So there is also malabsorption and various deficiency disorders of fat, protein, and vitamin deficiencies. A few have isolated perineal diseases. So we have perineal diseases, vomiting from jejunal strictures, or severe oral ulcerations. So we have isolated perineal diseases, vomiting from the jejunal structure, and severe oral ulcerations are present. The rectal sparing and the presence of perianal diseases are features that are diagnosis to Crohn's disease. So Crohn's disease can easily be diagnosed by rectal sparing that was not present in ulcerative colitis. And the presence of perianal disease means perianal area is also involved. There are perianal skin tags, fissures, and fistula that are found in at least 50% of the patient. So we have perianal skin tags, fistula, and fissures that are very important in the diagnosis of Crohn's disease. Now, types of Crohn's disease, depending upon the site of the involvement, it can be ileocolitis, jejunoileitis, colitis and perianal disease, and gastroduodenal disease. I will again repeat this: ileocolitis, jejunoileitis, colitis and perianal disease, and gastroduodenal disease. So these are the pictures where ileocolitis, you can see the ileitis, we have gastroduodenal Crohn's disease, jejunoileitis, Crohn's granulomatous colitis, and perianal Crohn's disease. Now what is ileocolitis? Ileocolitis is the site of inflammation is terminal ileum. So as the name suggests, terminal ileum causes ileocolitis, the presence with recurrent episodes of right lower quadrant pain and diarrhea. So there is pain in the right lower quadrant and there is diarrhea. The pain is usually colicky. There is colicky pain. It proceeds and is relieved by defecation. So there is colicky pain in the abdomen that is relieved by passing stool. A low-grade fever is usually noted. The weight loss, diarrhea, anorexia, and there is fear of eating. So there is weight loss, diarrhea, anorexia, no desire to eat, and fear of eating. There is edema, bowel wall thickening, fibrosis of the bowel wall. Within the mass account for the radiographic string sign. So there is typical string sign due to fibrosis of the or narrowing of the passage of the intestine, the narrowing of the intestinal lumen. Severe inflammation of the ileocecal region may lead to localized. So there is severe inflammation of the ileocecal region may lead to localized wall thinning, microperforation, and fistula formation to the adjacent bowel, the skin, or the urinary bladder, to an abscess cavity in the mesentery. There is enterovesical fistulas that are present as dysurias and recurrent bladder infections. There can be enterocutaneous. The enterovesical was related to the bladder. Enterocutaneous means intestine to skin. They follow tissue planes of the least resistant draining to the abdominal surgical scar. And there can be enterovaginal fistulas that are rare and present as dyspareunia or as a feculent or foul smelling of a painful vaginal discharge. Now the next condition is jejunoileitis. So in the jejunoileitis, there is extensive inflammatory disease that is associated with loss of digestive and absorptive surfaces, resulting in malabsorption and steatorrhea. There is anemia, hypoalbuminemia, hypocalcemia, hypomagnesemia, coagulopathy, and hyperoxaluria and nephrolithiasis. The diarrhea is characteristic, that is caused due to bacterial overgrowth in the obstructive stasis. There can be bile acid malabsorption due to increased or decreased terminal ileum. There can be intestinal inflammation with a decreased water absorption. Next one is colitis and perineal diseases. So it is present with low grade fevers, malaise, diarrhea. There can be crampy and abdominal pain and sometimes hematochezia. The pain is caused by the passage of fecal matter through the narrowed and inflamed segments. There is stricturing of the colon that produces symptoms of bowel obstruction. Colonic disease may visualize the stomach or duodenum or the proximal small bowel or rectovaginal fistula. In the perineal disease, it is manifested by incontinence, large hemorrhagic tags, anal strictures, anorectal fistulas, and perirectal abscesses. In gastroduodenal diseases, we have the signs and symptoms of upper GI tract disease like nausea, vomiting, and epigastric pains. There can be Helicobacter pylori, negative gastritis, and in the advanced gastroduodenal Crohn's disease, it may develop chronic respiratory obstruction. Now, what are the different lab investigations that could be done? We will find elevated PSR and CRP. There can be hypoalbuminemia, anemia, and leukocytosis. There can be endoscopic features that include rectal smearing, rectus ulcerations, fistulas, and staph lesions. In colonoscopy, the colonoscopy allows examination and biopsy of mass lesions or strictures and biopsy of the terminal media. There can be wireless capsule endoscopy that can be done that allows direct visualization of the entire small bowel. The early radiographic findings consist of cobblestone from longitudinal and transverse ulceration, most frequently involving small bowel. The earliest macroscopic finding of colonic Crohn's disease are aphthous ulcers. We find aphthous ulcers. As the disease progresses, aphthous ulcers becomes enlarged, they become deeper and occasionally connected to one another, forming longitudinal, sterate, serpiginous, and linear ulcers. The radiographic string sign that is most important in the case of Crohn's disease represents long areas of circumferential inflammation and fibrosis, resulting in the long segment of liver nerve. Both CT and MRI of the small bowel can be performed. Now, what are the different complications? As the Crohn's disease is transmural process, cell adhesions develop. There can be perforation, which can occur in 1 to 2% of the patients. There can be intestinal obstructions or massive hemorrhage. There can be a condition of malabsorption and severe perineal disease. Now, there are certain extraintestinal features that are also present along with Crohn's disease, which includes in the joints, we have peripheral arthritis, ankylosing spondylosis. In the skin, we have erythema nodosa, aphthous ulcers, pyoderma gangrenosum, and cutaneous Crohn's disease. In the eyes, the symptoms can be present with conjunctivitis, episcleritis, iritis, and uveitis. In the liver, there can be fatty liver, cholangiocarcinoma, and chronic hepatitis. The others include autoimmune hemolytic anemias, diabetes, pulmonary embolus, kidney stones, metabolic bone disease. These are the various extraintestinal manifestations, which includes conjunctivitis, iritis, episcleritis, mouth ulcers, fatty liver, liver abscess, and porphyria. There can be mesenteric or portal vein thrombosis. We have venous thrombosis, arthralgia of the large joint. We have erythema nodosa, pyoderma gangrenosum. There can be metabolic bone diseases, sacroiliitis or ankylosing spondylitis. The Crohn's with HLA-B27 can be found. There can be amyloidosis with oxalate calculi, or we can find the features of gallstones. Primary sclerosing cholangitis and cholangiocarcinoma or ulcerative colitis can be present to autoimmune hepatitis. So these are the various extraintestinal manifestations that can be present. Now, what is the differential diagnosis? In the differential diagnosis, we have bacterial diseases like Salmonella, gonococcal proctitis. We can have the symptoms of viral disease like herpes simplex, proctitis, cytomegalovirus. There can be symptoms of protozoal like amoebiasis, vascular ischemic colitis, idiopathic collagenous colitis, the drugs NSAIDs. In neoplastic, we have symptoms of colonic carcinoma and others are diverticulitis. Now, how will you manage the case of Crohn's disease? The management. This is the common management of IBD, that is inflammatory bowel disease. In the management of both ulcerative and Crohn's disease, we have to treat the acute attacks. We have to prevent the relapses. We have to detect the carcinoma at an early stage and we have to select the patient for surgery. So treatment protocol for inflammatory bowel disease consists of suppurative, that is antidiarrheal agents, loperamide, intravenous hydration and blood transfusion. We have parenteral nutrition. Always remember this is a treatment for both the condition ulcerative colitis and Crohn's disease. Sulfasalazine and aminosalicylates can be given to corticoids. There can be immunosuppressive agents because this is not an immune disease, so immunosuppressive agents which consist of azithromycin and 6-mercaptopurine. We can also give metronidazole. Now, there are various surgical procedures which can be performed. In ulcerative colitis, surgery involves removal of the entire colon and rectum. Colectomy for intractability, toxic megacolon, then proctocolectomy with ileostomy, or proctocolectomy with ileal anal pouch anastomosis. In case of Crohn's disease, the surgery for fistulas, abscess, perineal diseases, obstructing or fistulating small bowel diseases may require resection of the affected tissue. The surgery is not curative in Crohn's disease, and the disease recurrence is a rule because we have skin lesions, multiple areas are affected at a time. Now, this is the comparison of Crohn's disease and ulcerative colitis. In Crohn's disease, the site of origin in Crohn's disease is terminal ileum, with ulcerative colitis is rectal. The pattern of progression in Crohn's disease is skin lesions, whereas the ulcerative colitis spreads proximally, continuous. Thickness and inflammation in case of Crohn's disease is transmural, whereas in ulcerative colitis we have submucosal or mucosal. The symptoms consist of, in Crohn's disease, is crampy abdominal pain, whereas in ulcerative colitis we have bloody diarrhea. The complication in Crohn's disease is fistulas, abscess, and obstruction, whereas in ulcerative colitis we have hemorrhage, toxic megacolon. The radiographic finding in case of Crohn's disease is string sign or Bayesian X-ray, whereas in ulcerative colitis we have lead pipe, colon, or tube X-ray. The risk factor of colon cancer is slightly increased in Crohn's disease, whereas it is markedly increased in case of ulcerative colitis. The surgery in case of Crohn's disease is for the complications such as stricture, whereas in ulcerative colitis it is curative. So this was all about inflammatory bowel disease. In the next lecture, we will be studying about irritable bowel disease. So this session was powered by Digital Coaching 2.0 JAYOTI VIDYAPEETH Women's University. I hope you are satisfied with my digital session. If you have any query, please mention in the comment box and try to resolve. So this was all for today. We will be meeting in the next lecture tomorrow. So this was all for today. Thank you very much.